When stent bites back, lessons from acute stent thrombosis. This is a recently case done last month. 44 years female came with ACS, STEMI, anterior wall MI. LVF was 40%, no comorbidity, severe chest pain 2 hours back. Hemoglobin was 8, creatinine 0.9, took for PAMI, loaded with aspirin, ticagrelol, as well as low molecular weight. Heparin was given in the emergency department. This was the coronary angiogram. If you see, is having triple vessel disease with LAD type 3 LAD, which shows a long segment lesion extending beyond D1. And as well as if you see in the caudal views, the proximal LAD shows as a dissected, maybe dissected plaque. And RCA dominant, which was also a moderate disease. So I pre-dilated with NC 2.5 by 12 throughout the LAD. I got a TME3 flow, no reflow or anything after pre-dilatations. Then I took a 2.75 by 50, positioned from proximally to mid LAD, covering the lesions and deployed at 10 atmospheres. I had kept wire in the circumflex. I did a post dilatation by 3 by 12 NC at 14 and 16 atmosphere throughout the stent. And after post dilatation, this was my result. TME3 flow, no reflow or no slow flow. Post angioplasty, knee residual stenosis, no dissection was observed. Post PTCA, ACT was 150 in spite of giving 7,000 units IV heparin. So more 4,000 units IV heparin I gave. Patient was shifted to a cardiac ICU. I spoke to the relatives about the procedure. Initial stable. Post PCI 15 minutes. She had sudden onset of chest pain, diaphoresis, hypotension, shock, falling blood pressure, poor perfusion, continuous ventricular arrhythmias. We had shock, cardiac arrest, CPR. Temporary pacemaker was placed in the ICU. Then there was ST elevation, so I took her for again recheck angio, and I got this result. So I did a thrombosuction, continuous CPR for almost 30 to 45 minutes and balloon dilatation, but unfortunately I couldn't save this patient. So things I could have done differentially. Maybe imaging would have helped me. Maybe left main to LAD stent, rather doing a ostial LAD stent, or POBA to LAD and send early for bypass surgery. Possible lessons to learn: recognizing the early warning signs. Acute stent thrombosis usually presents within 24 hours. ST elevation, sudden hemodynamic collapse must always suspicion of acute stent thrombosis. Continuous ECG and hemodynamic monitoring in ICU is critical post PCI, and early detection and rapid response can save lives. So technical factors to prevent: ensure optimal stent expansion and opposition, avoid residual stenosis, edge dissection, adequate lesion preparation, consider aspiration thrombectomy and proper sizing of stent. Pharmacological lesions, again adequate doses of aspirin and ticagrelol and intraheparin, as well as watch for non-responsiveness. And high-risk post-PCI patient require close monitoring in CCU, immediate availability of cath lab, as I did re-angio, establish the protocol for early recognition, importance of multidisciplinary teamwork, and each case of stent thrombosis should be quality improvement opportunity for the cath lab team. So final take-home message: acute stent thrombosis is catastrophic. Always suspect with sudden collapse post-PCI. Meticulous technique and optimal stent deployment are the key preventive steps. Potent and adequate antiplatelet anticoagulant therapy is non-negotiable. Continuous vigilance and rapid re-intervention can make the difference between the survival and loss.